Chair now recognizes Dr. McNamara for 5 minutes for your opening statement.
Thank you, Thank you, Health Subcommittee Chair Guthrie, Ranking Member Issue, and members of the subcommittee. I'm a board-certified pediatrician and a specialist in adolescent and young adult health. I've spent 12 years in medical training and direct patient care and in clinical research. I'm honored to serve the diverse needs of young adults aged 12 to 25, and as an assistant professor at the Yale School of Medicine, I teach medical residents, students, and fellows. I am also the co-founder of the Integrity Project for Child and Adolescent Health, which seeks to infuse health policy debate with scientific evidence. My testimony today reflects my academic and clinical work, as well as medical consensus, and not the views of my employer. The amendment to the Public Service Act before you proposes to defund pediatrics training programs throughout our country if these institutions provide the standard of care to transgender youth. I'm honored to speak here today on behalf of esteemed colleagues throughout the nation who provide this best practice medical care for children and youth, including trans youth and their families. As a physician with a commitment to patient care, I'm honored to be able to do more for them here than I can do in the office. The past few years mark a rapidly shifting and hostile political climate towards medical care for transgender people with a harsh focus on youth. Care that should be a private matter for families, patients, and providers is now being directed by legislators based on unsupported fears and misinformation. I understand that this care may be confusing to those who are not medical providers with expertise in treating this population, or those who do not have a personal connection to a transgender person. That is why it is critical that this body base its decisions on facts and accurate information. Most of us here would not disagree with that. From my position as a medical practitioner and a member of a large community of experts in this care, I see 5 categories of misinformation. Denial of the medical condition of gender dysphoria, false claims about standard practice, false claims about the evidence that backs care, false claims about the safety of treatments, and an attack on medical authority. And I'm here to ensure that you have the facts to address this misinformation. Gender dysphoria, the long-standing and significant distress that many transgender people have from the incongruence between their gender identity and the sex they have at birth, is real. It's a recognized and serious medical condition. Transgender people of all ages exist. Their healthcare is based on established standards of care and clinical practice guidelines, which are themselves based on substantial medical research and evidence, as well as decades of clinical practice. Based on these standards, youth and parents receive informed counseling about the risks and the benefits of specific treatments, and every major medical organization has endorsed this care. As a pediatrician, I must also address the proposed amendment. Pediatrics residencies and fellowships are the backbone of healthcare for children in this country. During the triple-demic of influenza, COVID-19, and respiratory syncytial virus, also called RSV, it was pediatrics residents and fellows who worked every hour of every day to help children survive life-threatening respiratory diseases. They help NICU babies get to kindergarten. They keep outpatient clinics flowing so the kids get routine well care. Residents and fellows form a pipeline of research and innovation that makes this country a global leader in every area of pediatric medical science. This bill would require children's hospitals to deny kids health care to maintain funding. As a practical matter, there is no way to banish all transgender youth from children's hospitals, nor is there a way for pediatricians to simply refuse to provide these youth with medically necessary care. All kids suffer when their legislators remove parents' rights and prevent pediatricians from providing this standard of care. And I have to tell you, American pediatricians will not accept being told that they have to leave even a single child behind. There's no room in our clinics for the government. I had a conversation with a trans teen recently. Gender dysphoria began early in puberty and worsened as puberty progressed. The parents sought and received help. This family asked me to tell members of this committee that gender-affirming care gave their kid confidence. This teen stands tall, debates international law and Model UN sessions, recently in this city, our capital, to compete in nationals. This care was life-saving, life-affirming. College options are limited to states that protect trans healthcare, but even still, this teen is excited for the future that lies ahead. That's what every kid in this country deserves. Please don't make it harder for us pediatricians to get them there.
Thank you. Thank you for your testimony. The chair now recognizes Dr. Grossman for 5 minutes for your opening statement.
Thank you, Chairman Guthrie. Chairman Guthrie and members of the subcommittee, thank you for the opportunity to address you. My name is Miriam Grossman. I am a board-certified child, adolescent, and adult psychiatrist, author, and senior fellow at Do No Harm. I have been taking care of patients for 45 years. I'm going to use my time to respond to Dr. McNamara. First, I'm struck by her use of the phrase, sex assigned at birth. Sex is not assigned at birth. Sex is established at conception, and it's recognized at birth, if not earlier. Dr. McNamara claims that her views are science-based, but to claim that sex is assigned at birth is without any scientific basis whatsoever. Its language misleads people, especially children, into thinking that male and female are arbitrary designations and can change. That is simply not true. Dr. McNamara claims that social and medical interventions are the only evidence-based treatment and that scientific evidence shows it is life-saving. Without it, she's warning us, kids will commit suicide. Well, a growing number of countries have effectively banned the care to which she's referring. And thank God there's been no wave of suicides or other mental health catastrophes. 3 years ago, Finland placed strict limitations on medical interventions for minors. Sweden did the same thing after a 14-year-old girl was found to have osteoporosis and spinal fractures from puberty blockers. An investigation concluded, quote, the risks of anti-puberty and hormone treatment for those under 18 currently outweigh the possible benefits. The UK conducted a review and called the evidence very low. They've also placed severe restrictions on the care that Dr. McNamara calls life-saving. Norway also analyzed the data and has made similar changes in policy. The National Academy of Medicine in France warned, quote, great medical caution must be taken in children and adolescents given the vulnerability of this population and the many undesirable, even serious complications the therapies cause. Doctors in New Zealand and Australia have published similar statements. Is Dr. McNamara suggesting that all these countries are rejecting evidence-based treatment and placing their kids at risk of suicide? Regarding that point of view, Finland's gender expert, Dr. Rita Kaltiela, said, quote, it's purposeful disinformation, the spreading of which is irresponsible. All 7 countries, and Florida too, of course, concluded that kids don't need their development interrupted, the girls don't need their periods stopped and their voices lowered, and the boys don't need to grow breasts. What they need is psychotherapy. I have other objections to Dr. McNamara's testimony. She insists that her position, only hers, represents standard medical care. What she doesn't want you to know is that there is no standard. There's a debate. There's a fierce debate. And on the side opposite her stand such prominent figures as Stephen Levine, Kenneth Zucker, Paul McHugh, and James Cantor, among others. These doctors are giants in the field. They have been treating transgender patients and gathering data and publishing papers about them, and I mean no disrespect here, but since before Dr. McNamara was born. The point is that those veteran clinicians and others who have wisdom and experience are ignored because they disagree with the current narrative. They're against medical interventions for the same reason those 7 countries are. There is no evidence of long-term benefit, but there is evidence of harm. I'll end by quoting Jamie Reed, the courageous whistleblower from the Children's Gender Clinic in St. Louis. I believe that that hospital receives the medical education funding that we're discussing today. She said that doctors at that clinic said, "We are building the plane while we are flying it." We are building the plane while we are flying it. That's how they described the treatment at their gender clinic. Our precious tax dollars should not support such a perilous experiment. Thank you.
To Dr. McNamara, you just sat through testimony that I believe is chock full of dangerous misinformation and pseudo-scientific, quote, facts warped to fit, I think, a really outdated narrative of the trans experience in our healthcare system. We could spend a long time talking about that, but I want to give you the opportunity for a minute to respond. I've spoken to pediatric endocrinologists in my district who treat hormone disorders in children every day. And as we all go about doing whatever we're doing, this is taking place. This is taking place in our country. And it includes, which I was not aware of, early cases of early puberty in children as young as 2 years old. I'd never heard of that. This causes, obviously, a lot of serious issues. One of the treatments is providing GnRH, analog therapy, a banned medical intervention under the legislation that's being considered here today. And I again, to have, 2-year-olds, 6-year-olds, youngsters subjected to this is, well, I think you can hear it in my voice. I'm deeply unsettled about this. Do you want to, 30-second response? Since I
Thank you,
ate up
Dr.
some of your
Silver.
time?
Yes. So all 5 themes of the misinformation that I've identified in my work are on display. I'm a co-author of extensive rebuttals with science to all of them. It's entered into my testimony, and those documents have been used to successfully challenge bans on care for trans youth in Texas, Florida, and Alabama. The other testimony espouses 2 levels of harm: abolishing evidence-based care and creating a vacuum. The forced withdrawal of care is akin to experimentation. Dangerous, discredited conversion practices that attempt to convince a young person that they are not gay or not trans. We've moved on from that. Most states have banned that care in this country. It is toxic for an adult to tell an adolescent that there's something wrong with them. I'm sure there are many parents in the room, and you'd never want your kid to go through that. Suicidality is a debilitating way to endure adolescence. A suicide attempt is a traumatic interruption in a young person's life. Let's be clear. Pediatricians know that life-saving means life-sustaining. When trans youth receive the standard of care, they thrive. They develop talents, they discover their strengths, and they get to be who they deserve to be.
Thank you. Kevin, I wanted to know why CDC took almost 5 years to implement the legislation, and now we're reauthorizing it. But I think you're going to have to maybe answer that question for someone else, but at least to get it on the record. Thanks
Okay.
for being here.
Yeah, we'll have the
Thank you
chance
to
where we
you.
can do it.
I yield
and item
back,
moving
Mr.
forward.
Chairman.
Thank you for yielding back. The chair now recognizes the chair of the full committee for 5 minutes for questions.
Just to clarify, the bill does not ban treatment for precocious puberty, which the ranking member just alluded to. So a recent report found that the number of clinics in the United States focused on providing puberty blockers, hormone therapies, and surgeries for gender-affirming care has grown from just a few to more than 100 as of February 2023. Dr. Grossman, in your written testimony, you mentioned how certain European countries have decided to take a more cautious approach and significantly limit the use of puberty blockers and hormone therapies to treat gender-related conditions in minors. Is the United States an outlier?
Well, it's certainly, yes, more and more becoming so. I just want to take one moment, because this is really bothering me. Representative Eshoo, I'm sorry if I'm mispronouncing your
That's right.
name. Representative, you are very confused about something. When we, when,
I'm sorry, just, we'll be able to suspend?
yes, Representative, I'd like to clarify something for you.
You can clarify it to me. Clarify it to me.
Yes, precocious puberty is a medical condition. It's a condition in which the child
What's that?
has abnormal.
I'm sorry, would you,
You
could you
spoke to
spin
me
the clock a
directly,
second?
Mr. Chairman. You can't characterize me.
Okay, you can't characterize with the way that she's, her
okay,
question, what she's asked, so if you just respond to,
Okay, I'm
to the
sorry.
chair who's
Yes.
asking the question.
Okay. The point is that precocious puberty, which we've treated with blockers for decades, and is approved by the FDA for that use, that is a medical disorder. That is a disorder in which the child has abnormal hormone levels circulating that causes their bodies to prematurely enter puberty. We do not want that to happen. We're talking about an experimental use of these agents in children that are completely healthy. They have no medical disorder. So we are artificially blocking a biological process, a natural process called puberty. Puberty is not a disorder. We need to go through puberty in order to reach adulthood. Every system of the body, the brain included, needs to go through puberty to reach adulthood. And what we are doing in gender-affirming care is stopping that natural, organic process and blocking it, and then shortly thereafter, in most cases, over 90% of cases, administering the hormones of the opposite sex so that the child will go through a synthetic puberty, not the organic puberty.
Thank
But
you.
a synthetic puberty. Okay,
Thank
I'm
you.
sorry. You asked me about the European countries.
I asked you if the United States was an outlier.
Absolutely. The United
Okay.
States and
Thank
Canada
you.
are out.
And would you speak to what the data tells us about the long-term impacts of these medical interventions?
So that's the thing. You see, this, until recently, was an extremely rare condition. It was so rare that when I went to medical school decades ago, I never expected to see one case in my life. That's how rare it was. And now that's all I do. So you see, in the past 10 years or so, specifically since maybe 2015, there's been an explosion of cases, an absolute tsunami of cases. And the question is, why is that? And those cases are very different than previous cases. This is a new population. The prior gender dysphoric cases that we studied were mostly
you.
boys.
Okay, yes, thank you. I wanted to get to girls too, because I mentioned my concern about the mental health crisis for young girls. And over your career, would you speak to how patients experiencing gender dysphoria changed in the number and characteristics, and also speak to the long-term impacts for these medical
Okay, so what I wanted to say is that when we speak about long-term, we don't have the data yet because this is a new population called ROGD, Rapid Onset Gender Dysphoria. And we are just studying them now. It's a new demographic, mostly girls, but lots of boys as well. My practice is 50% boys. These are kids who have a lot of previous mental health conditions.
Thank you, Dr. Grossman. Thank you. I'm going to have to cut it off there, because I heard my colleagues say that this should be a private decision between parents, teachers, and parents, children, and doctors, that we should protect parent rights, and that Republicans are putting politics between children, parents, and the doctor. The truth is, parents are being removed from their children's doctor's offices, and kids are being taken from their parents and their homes. It's making it us versus them. That is my fundamental concern. I yield back.
Thank you. The chair yields back. The chair now recognizes the ranking member of the full committee, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. I have to say, I'm deeply disappointed in the partisan Children's Hospital GME legislation being considered today. It prescribes in very minute detail the types of care that must be prohibited in order to receive funding and tells our healthcare providers, major medical associations, and patients that Republican members of Congress know better than them about what should be considered standards of care within our medical system. And that should scare us all, particularly when this program is designed to train the next generation of pediatricians and pediatric subspecialists. So my questions are of Dr. McNamara. I know that transgender people and those who advocate for the rights of transgender people are currently facing fear, intimidation, threats of violence, but I believe that we must speak out on their behalf and support them, and I want to say thank you to you today for doing so. Now, turning to my questions, if this bill were to become law, what would the impact be on pediatric care?
So I'm very privileged to sit next to two people who have shared details about the types of medical care that benefit patients who I've cared for in my career, people with sickle cell disease, premature babies. Many people here might not know what goes into that type of care, but I do. And it's not my specialty anymore. I have subspecialty training in adolescent medicine. But the experiences that I had in a NICU in the middle of the night, resuscitating preterm infants, counseling their parents, working with my colleagues, offering advanced treatments for sickle cell to children with crippling pain, have forever shaped my training. I am an excellent clinical researcher because of my training as well. And I think that I am not the only person. You know, I spoke to so many of my colleagues about this testimony. Everyone expressed disbelief and regret that it would escalate this far. Everybody wants children to be healthy and safe, but their care and what they require to be healthy and safe is expert. We know what we're doing. We know how to do it really well. And all that we ask is that we be allowed to do it without any sort of legal interference.
I appreciate that. I mean, what I'm seeing here and in so many different forums is Republicans and Republican congresspeople trying to or determined to substitute their opinion for experts in medical fields, experts in agencies, and it's truly scary. The legislation is not only an attack on transgender youth and their families, but it's an attack on providers and the training they receive. Can you speak to how this would impact the training that pediatric residents receive? Briefly, because I have one more question.
Yes, of course. We're already seeing that less people are looking to go into pediatrics because it's been politicized and interfered with. There's a great deal of moral injury that accompanies being told what you can and can't do and needing to legally withhold care from people who need it, whose lives depend on it. So I would expect not only would it cut off at the knees the vast majority of training for pediatrics residents and fellows in this country, but it would deter the future of pediatricians.
So what you seem to suggest that this would have an impact on the pediatric workforce. You want to comment on that?
It would have a devastating impact on the pediatric workforce. People would bring sick kids into children's hospitals, and there wouldn't be anyone there to take care of them.
Well, thank you. You know, Mr. Chairman, I can't understand why the majority has chosen to hijack this critical program to have an ideological battle. I just don't understand it. This committee has a long history of working together to solve important healthcare challenges and training our healthcare workforce being one of the most important. It's just disappointing that instead of considering Representative Schreier's bill to reauthorize this program on a bipartisan basis, as we've done in the past, the Republican majority has instead decided to jeopardize the reauthorization of the CHGME through this harmful and inhumane policy. And I just don't understand it. I urge my colleagues to strongly oppose this bill, and I yield back, Mr. Chairman.
Touch on two different topics here today. First, I would like to address the policy that would pull funding from children's teaching hospitals that provide age-appropriate, gender-affirming care for transgender and non-binary youth. I echo my colleagues who have already spoken out to protect the relationship between patients and their doctors, and this harmful and misleading rhetoric and policy that purports to protect kids is actually doing the opposite. It is a bully policy that bullies some of our most vulnerable kids. Research shows that gender-affirming care improves the short and long-term mental health and well-being of trans and non-binary youth. The science is there, the studies are there, and every major medical association supports it. Decisions to get age-appropriate, gender-affirming care is one that should be made by parents and their kids in consultation with their doctor, not by the federal government. And in addition to placing transgender and non-binary youth mental health at risk, these policies are also risking the future of our pediatric workforce. We already have a pediatric shortage. Children's hospitals train half of our country's pediatricians, and this proposed policy only forces those hospitals to choose between doing what is best for their patients or training the next generation of pediatricians. Dr. McNamara, as a doctor, and I'm very concerned how this policy will harm the mental health of our transgender and non-binary youth, as well as the future pediatric workforce of our country. Can you address the consequences these policies will have both on our transgender and non-binary youth and on our pediatric workforce?
It all goes hand in hand, sir. Thank you for your question, because it highlights the fact that pediatric healthcare is a tightly knit fabric, and you cannot pull out one thread. The whole tapestry would unravel. The healthcare of one child is, we don't think about it like that, I guess. We don't parse out groups of youth and say, well, it's okay to care for you and it's not okay to care for some of them. So we simply would never accept this policy. As far as mental health goes, even just the rhetoric that we've heard today is very damaging and harmful to trans youth. I think that one of the reasons why rates of suicidal ideation over the past couple years and other mental health harms in trans youth has been going up is because of how they've been demonized.
Yeah, and the rhetoric leads to depression, leads to anxiety, leads to suicidal ideation. It also encourages others to use the same rhetoric, their peers, that leads to bullying. Transgenders are already number one on the hate violence crime list. So I'd like to pivot to another topic.
It's critical that we support our nation's children's hospitals. Nothing is more important to me than ensuring the mental and physical health of our young people. That's why I'm proud to support Representative Crenshaw's legislation reauthorizing the graduate medical education payment program. Yes, I am deeply troubled by reports that a growing consortium of American medical professionals are pushing highly controversial treatments like gender-affirming surgeries, hormone therapy, and puberty blockers on children and teenagers when we do not know the true impact of their long-term mental and physical health. So question number one, Dr. Grossman, in your position as a child, adolescent, and adult psychiatrist, what types of treatment methods for kids diagnosed with gender dysphoria are backed by scientific data? If you need me to repeat that, I will.
No, I heard you. Thank you very much, Congressman, for the question. We have known for decades that if these kids are left alone or just given psychotherapy and family support, that the vast majority will become comfortable with their sex, with being a boy or a girl. Mm-hmm. We've known that for a very long time. Recently, we've started applying so-called gender-affirming care to a new cohort, a new group of kids that we've never seen before. And those are kids who suddenly, out of the blue, develop the gender dysphoria as part of what more and more people are realizing is a social contagion.
So you're saying that if they receive the kind of support at home and mental health counseling, traditional mental health counseling, that they grow through this phase and they become comfortable with who they are.
Yeah, I'm not saying every single
Sure.
person.
Sure.
But in the past, the research that's been done on those kids would say so.
Well, that's interesting because, as my colleagues across the aisle frequently like to say, we need to follow the science here. In Dr. Grossman's opening remarks, she noted that the United States is moving in the opposite direction from our European counterparts in terms of how those nations view gender dysphoria treatment. Simply look at our friends in Great Britain. Just recently, the National Health Services in London announced that publicly funded services will no longer routinely offer puberty-blocking drugs to children. This on the back of a 2023 global public opinion survey of 30 countries asking whether or not transgender teens should be allowed to receive gender-affirming care. This survey showed the United States as having even less public support for these treatments than virtually every single European country polled, including the UK. The fact of the matter is the United States is moving in the wrong direction. It's moving in a very extreme direction and is becoming a global outlier on this issue. I personally believe it is irresponsible and essentially child abuse to allow minors to make these types of life-changing medical decisions. But on the facts, we simply do not know enough to say for certain that we should be allowing these treatments at all. I find it disturbing that some children's hospitals are pushing puberty blockers or hormone therapies on children incapable of understanding the long-term effects of these treatments. Children's hospitals are meant to be the gold standard of pediatric care in our communities, and their support for such programs will lead parents and families to trust what they are saying despite the data telling a different story. I do have other questions that I'll submit for the record, Mr. Chairman. I realize my time has expired. This is a real important and emotional issue for many of us, especially those of us who are grounded in our faith and as parents. We see this as an aberration.
Gentleman's
and
time has expired.
I yield back.
I now recognize Ms. Custer for her 5 minutes.
Thank you, Chairman Guthrie. I'm glad this committee is dedicating time to reauthorizing several important health programs, all on a bipartisan basis. The list is impressive: supporting premature infants, expanding the dental workforce, committing federal resources to end Parkinson's, protecting our firefighters, to name a few. Today's hearing should be an opportunity to celebrate the important role that Congress plays in dedicating resources to people with rare diseases and providing support to our country's health workforce. However, I am extremely disappointed as a parent that today's hearing includes a partisan attempt to villainize children and bring politics into our healthcare system. I recently had a lovely breakfast with our chair. We share a concern about the well-being of our youth. But I want to quote her comments at the beginning of this hearing. She said she wants to send a message to our children that they are loved as they are. Trying to scare our nation's pediatric hospitals into denying gender-affirming care to patients to fit a political agenda is not just cruel, it's nonsensical, and it puts the health of millions of children at risk. As Dr. Ruiz has recounted, and our experts today have affirmed, this type of rhetoric from members of Congress in hearings like this leads to suicidal ideation and bullying and is harmful to our children. Let's make one thing clear right now. The government has no role in policing what care doctors and nurses should provide to their patients. Medical decisions are between a patient, their family, their parents, their guardian, and their physicians. Trying to insert the federal government into these incredibly private, incredibly sensitive decisions is simply unacceptable. In my home state of New Hampshire, our state motto is to live free or die. We value privacy. We value the privacy of our medical decisions, and we do not need the United States Congress to interfere in that privacy. This legislation flies in the face of our state motto. So, Dr. McNamara, in your testimony, you state that healthcare providers must consult with parents and legal guardians about care that's provided to children. Could you explain to this committee and to my colleagues the importance of informed consent when providing all kinds of medical care to our youth?
Absolutely. Thank you for your question, Congresswoman, and thank you for your comments. It makes my patients feel safer. So parents play a central role in all medical decision-making for minors in the vast majority of cases, and regarding medical treatments for gender dysphoria, it's no exception. Parents know their kids best. They know what they need. We as pediatricians rely on their knowledge of their young person in order to help support them best. In the case of medical treatments for gender dysphoria, the standard of care and the way that care is practiced in this country is with a multidisciplinary team with an iterative over several visits, several months mental health assessment, and long conversations that don't really have an endpoint. That may be a little bit different from other aspects of pediatric care, but it's something that my colleagues and I are very skilled at doing. We know how to do it, and this care overwhelmingly benefits transgender youth.
I just have to, as an aside, I was an adoption attorney for 25 years, and I primarily represented birth parents who made the decision to place their children for adoption. And I can remember working with 2 teenagers. I remember when we went before the judge looking over and realizing that the young man had never shaved. He still had the peach fuzz on the side of his face. And trust me, there was no room for the federal government in making those personal, private decisions about our health, our well-being, and the well-being of our families. I just want to say that the claims that we hear about gender-affirming care in this room and in the media are dangerous, and I want to join my chair in sending a message to our children that they are loved as they are. Thank you so much. I yield back.
Gentlelady yields back. I now recognize myself for 5 minutes for my line of questioning. I am a physician, and I understand the issues related to gender dysphoria. And I do recognize it's real. However, I can never support permanent surgical procedures on children, regardless of the other need for treatment for their dysphoria. Again, I would remind everyone these are irreversible. Permanent surgical procedures, in my view, should not be part of a treatment plan for transgender children. And I recognize now Ms. Craig for her 5 minutes.
Thank you so much, Mr. Chairman. I'm incredibly disappointed to see my Republican colleagues today taking what has always been a bipartisan effort to reauthorize a program that we've always supported and twisting it into a partisan process that undermines parents' rights and ignores evidence-based care guidelines for the treatment of trans youth. We should be here today to support a clean reauthorization of the Children's Hospital Graduate Medical Education Program. But oh no, you're putting the program in jeopardy in support of your continued culture war crusade. Look, I have a newsflash for my colleagues. It is none of your business what evidence-based care a parent in consultation with their healthcare provider decides for their child. In fact, after listening to you today, I am absolutely certain that most of you have no idea what the range of gender-affirming care actually is. So let me start with that. Dr. McNamara, can you define for us what age-appropriate, gender-affirming care actually is for my colleagues? Just a little bit.
This is absolutely crucial. Thank you so much for the question. Gender dysphoria is real. It represents a discordance and distress that emerges from the difference between, I mince my words. It's the difference, and I mince my words again, I'm so sorry. It is distress that emerges from the difference between sex assigned at birth and gender identity. Without treatment, this care with this condition is dangerous and debilitating. Gender affirming care starts with affirmation. It starts with very simple things like, is it okay to get a haircut? Is it okay to wear certain clothes or to change your name into something that feels more authentic? And from there, we see that youth begin to blossom. Some youth qualify for and desire medical aspects of gender affirming care. And it's a highly individualized process. It depends on who the young person is, their parents, and the conversations that evolve from there. There is no endpoint, and there is no prescripted plan of care. It depends on the person who's before us.
And Dr. McNamara, that care has been supported by 20 major medical associations, including the American Academy of Pediatrics, the American Psychological Association, and the American Medical Association. Am I correct?
Absolutely.
Can you, just for a moment, rebut the claim that has been made here today that the United States is somehow an outlier in the care that gender-affirming care represents?
So I urge this body to make any decisions based on sound information and science. No other country in the world who is a peer of the United States has gone as far as to ban and criminalize the provision of medical treatments for gender dysphoria. What you have heard today is a cherry-picked collection of unverified information that portrays outlier views in some countries in this world. There are many countries in this world that nobody has brought up today that I could list off, like Ireland, Australia, Spain, Portugal, Canada, Mexico, among others. But this is the greatest country in the world, right? And our medical science and innovation here is amazing. I'm so privileged to be able to practice this care.
Dr. McNamara, thank you so much. You've already spoken to how dangerous it can be if that care is denied or if medical professionals are not appropriately trained in order to treat this and provide this care. I get that some of my colleagues think this topic is a political winner. I would extend an invitation to every single one of you, many of whom I respect, to attend a panel of parents of trans youth to hear their stories. What you are attempting today undermines the rights and responsibilities of the parents of trans kids and is opposed by all the major medical organizations in our nation. We agree, Madam Chair, I have so much respect for you, that the goal is to love our children for who they are. Some of our children are transgender. Do we have enough space in our hearts to love and accept them too for who they are? Some of your kids and grandkids will be trans. Do you really want any politician sitting in this room involved in their health care decisions? And with that, I yield back.
I was just going to ask Dr. McNamara, first, thank you for speaking so beautifully about the care of transgender kids. And if you want to add anything or correct the record on that, you are welcome to do that in the remaining minute. But I also wanted to ask you whether this direct primary care model, how that would affect your practice and the relationship you have with your patients.
Thank you, Congresswoman, and it's a pleasure to speak to a fellow pediatrician. Primary care is the foundation of health and wellness in this country. It's a privilege to take part in our primary care system and to see children flourish into adolescents who become my favorite patients. As far as correcting the record, it is difficult to do so in a way that does justice to the amount of misinformation that we have all heard today. I urge this body to deliberate over the extensive documents that have been submitted to the record that debunk this disinformation and misinformation, and to base their decisions on science.
And I will just add in my 10 seconds that I appreciate your noting how much engagement with the patient and the family happens with counselors, psychologists, psychiatrists, physicians, endocrinologists, to make sure that you've got this right and the care that these children and young adults really deserve. I wanted to call attention to that thoroughness and the care that you provide. Thank you. I yield back.
Thank you. Congresswoman yields back. The chair now recognizes Mr. Crenshaw from Texas for 5 minutes.
Thank you, Mr. Chairman. I first want to thank my friend, Representative Schreier, for her great bipartisan work on the direct primary care bill that we've been working on. It's, look, there's a lot of things we can agree on, and this is certainly one of them. And this is a small step in the right direction. I'm really excited that we're gonna get this through. But now there are some things we disagree on here, and that's what we've been talking about a lot in this hearing. So let's shift focus to the giant elephant in the room. And this is the reauthorization for the Children's Hospital's GME funding. And yes, it's true, this is my bill. And what it does is it withholds funding from these hospitals if they engage in what they call gender affirmation therapy, these physical changes to a child's physiology, permanently disfiguring them through either puberty blockers or even surgical modifications. Now, look, I understand that the other side of the argument here believes they are on the side of compassion, and maybe that's a sincerely held belief. It is just as true that I believe we are on the side of compassion. I think it is indeed compassionate to stop kids from being permanently physically altered based on little to no evidence that it will improve their underlying mental condition. Now, why is this controversial? That's actually beyond me. Not too long ago, I think we all agreed that performing double mastectomies on a 12-year-old girl was wrong. Now it's become a political movement where radical activists have bullied mainstream medical associations and members of Congress into repeating this propaganda. Now, it should be noted that in the public, this subject is actually not very controversial. In fact, a recent poll just last month by the Washington Post showed that 68% of Americans opposed using puberty blockers on children. That's just a question about puberty blockers. Imagine if the question had been about castration or surgical interventions. So you've got to convince me that 70% of Americans are just a bunch of fools that refuse to accept the so-called science. Or maybe, look, I have another theory. Maybe they have a very baseline understanding of ethics and common sense, which tells us that maybe, just maybe, it's a bad idea to submit children to permanent life-altering medical interventions based solely on a temporary ideation about their gender. Gender affirmation is not science, and there's no evidence-based standard of care. To say that is a lie, or is at best redefining the term evidence-based. What this is a social contagion. It is based in pseudoscience and radical ideologies. And it's sweeping across our country and encouraging children to make irreversible changes to their gender. What's worse, it's coming from adults and institutions who know better, to include our children's hospitals, institutions that are supposed to be tethered to sound science and their Hippocratic oath of do no harm. Now, maybe I'm an optimist, but I do believe that science and evidence will win out in the end. In the future, we will look back at these gender-affirming therapies as we now look at lobotomies and electroshock therapies. I have some reason to be hopeful. Notably, Great Britain's National Health Service restricted these clinical interventions for minors just last week. Reviews published in the British Journal of Medicine, the Journal of the Endocrine Society, even in the American Academy of Pediatrics, all cite the lack of evidence. I'm going to submit for the record this review published in the Journal of Endocrine Society that found that there is, quote, low-quality evidence for the idea that hormonal treatment improves quality of life, depression, and anxiety among adolescents. Now, here's the important part. This was a systematic review, which by definition is not cherry-picked data, but it's an all-encompassing review of all the data. It has thoroughly debunked the notion that any of these treatments are, quote, evidence-based, let alone recognized as, quote, standard care. My colleagues are using these terms not as accurate representations of the data, but as propaganda. Now, this funding program is reauthorized every 5 years. It provides taxpayer funds to train resident physicians at children's hospitals across the country. It's true, it's been a bipartisan funding mechanism for years. Let's keep in mind something, though. This is taxpayer money. And when 70% of taxpayers oppose these barbaric treatments on minors, then taxpayer money should not fund it. That's why I'm stipulating that as part of this reauthorization, we will not provide any funding through this program to children's hospitals that push gender transition on minors through puberty blockers, hormone therapies, and surgeries. Let's be clear, because there's another lie that's been told. It does not prevent any mental health therapies at all. Despite these lies being told, it does not prevent those kind of therapies at all. This is the issue of our time. This is a hill we're going to die on. It's too important. It's too important to protect our kids from this. In my very limited time, I have too much limited time, so I'll wait for my colleagues to yield to me to ask questions, and I yield back. Thank you, Madam Chair, or Mr. Chairman.
Appreciate that. Boston Children's Hospital is home to the first pediatric and adolescent transgender health program in the United States. However, misinformation has repeatedly spread online suggesting the hospital performed gender-affirming genital surgeries on young children, when in reality, surgeries are only performed on consenting adults. But that hasn't stopped healthcare workers at Boston Children's from being subjected to threats and attacks. Threats and attacks, by the way, that are a direct result of a coordinated campaign designed to, and I'm quoting a conservative political action conference speaker here, eradicate transgenderism. And by inviting a witness to elevate that dangerous rhetoric in the United States Congress, the majority is allowing a target to be painted on the backs of some of our nation's most vulnerable children and the healthcare professionals they rely on. Dr. McNamara, can you speak to the dangers of increased threats and attacks on our nation's pediatric healthcare professionals? And do you think this intimidation undermines their ability to recruit specialists or continue providing a high level of care?
I absolutely do. I think if I was a medical student looking at the current political climate, it would feel overwhelming.
I appreciate your candor, Doctor. Time and time again, I've heard my colleagues across the aisle discuss the urgent need to address the youth mental health crisis. But we can't do that if we ignore the fact that trans youth are suffering higher rates of mental illness, higher rates of suicide ideation, and higher rates of self-harm, a problem with a large body of medical literature demonstrating that with support at home, in school, and in communities, coupled with access to gender-affirming care, trans youth do as well on mental health measures as their cisgender peers. We should be working to increase access to health care for all of our children, not to restrict the ability of children to define and express themselves. A ban on gender-affirming care is dangerous, it's misguided, and it's cruel. And it's a shame that Republicans are using what should be a bipartisan piece of legislation to contribute to the dangerous attack on our most vulnerable children. They deserve better. I yield back.
The gentlelady yields back. The chair now recognizes Dr. Dunn for 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate the hard work this committee is putting in to ensure that critical public health programs do not lapse this year. I'm pleased with the level of bipartisan collaboration shown to ensure that the programs that are aimed at improving childhood and maternal health serve our most vulnerable constituents. We're also supporting research to fight rare diseases. I do want to take a moment to echo the comments of my colleague, Dr. Burgess, regarding the Children's Hospital GME program. I appreciate the bill put forth by my colleague, Mr. Crenshaw, to protect children from harmful gender-improving care and hormone therapy. And I understand that many children may feel immense peer pressure and psychological distress for many different reasons. These children need loving, caring parental involvement, they need emotional support, and they need highly specialized medical experts with their best interests at heart. It's a monumental decision to undertake gender transition surgery on a potentially fertile person. The radical race to embrace gender transition is undoubtedly harming some of our children. When considering pediatric GME, it's critical that we strike the right balance between banning appropriate treatments and procedures and properly equipping physicians with the skills and the knowledge they need to perform complex surgeries and inform the choices that patients and parents make. There actually are unique cases in which a baby is born with genetic disorders that cause truly ambiguous genitalia. This is a mix of male and female reproductive organs. As a urologist, I'm very familiar with such cases. Medical and surgical interventions may be needed to mitigate harmful side effects and even to save lives. In these cases, it's important that pediatric urologists have the specialized knowledge and the proper skill sets to make the best decisions with the patients, with the consent of their parents. I actually do not have any questions, Mr. Chairman, and I'm willing to yield time to anybody on the panel. Mr. Crenshaw, I recognize you.
Thank you, my colleague. Thank you to my colleague, and I do have a few questions. I want to say a few things. First, we keep hearing this is a politicized issue. This is a manufactured culture war. I got to say, we aren't the ones who did that. We aren't the ones that came up with this radical new movement that is performing permanent physiological changes to children with no evidence of any benefits. We didn't start that. We're just trying to stop it because it's crazy. It's a contentious issue, which almost 70% of Americans oppose. So we are just saying here that taxpayer money shouldn't be used for it. That's all. This should not be that controversial of an issue. Questions are for Dr. McNamara. I just want to ask you, honestly, you're not concerned about the unknown effects of puberty blockers, hormones, and surgical interventions in kids, the long-term effects, not concerned about that?
Everything I've said here today comes from a place of deep honesty and conviction for the care that I provide and the community that I'm a part of.
You've said that we've cherry-picked data. How do you mean how do you mean that?
So it is very unscientific and flawed to pick a single study or a single statistic and to discuss it in isolation.
Totally agree.
Medical experts are able to talk about all of the evidence as a whole.
Totally agree. So it's good to look at systematic reviews, right? That's the gold standard of evidence when you're trying to understand whether something works or whether it doesn't. So the British Journal of Medicine looked at 61 systematic reviews with the conclusion that, quote, there is great uncertainty about the effects of puberty blockers, cross-sex hormones, and surgeries in young people. The Journal of Endocrine Society came up with the same conclusion, even the American Academy of Pediatrics. They all cite the lack of evidence. And so here's the thing. If you're doing a therapy and it's, temporary, whatever, fine, maybe let's try it, let's see if it works. But when you're talking about permanent physiological changes, do you not agree, just from an ethical standpoint, that you might want extremely strong evidence of the benefits? And there is no systematic review that states that there is strong evidence of benefits.
Sir, are you aware of how the quality evidence grading system works and how it's applied?
Yeah, we've read through it. That's why I'm citing these journals. So which journal says something different? We should have that debate. Tell me a journal that has done systematic reviews that cites different evidence, that cites strong evidence for benefits of these therapies.
The standards of care were developed based on extensive.
You're not telling me any journal, you're not telling me any study. Don't say
That's not
standards
what
of care.
Yeah. So.
Tell me one.
The standards of care.
That's the standards of care.
Yes,
That's
standards of
not
care.
a journal, that's not a study. That's not an organization, that's not an institution. You're just saying words. Name one study. I'm out of time. I yield
The
back.
gentleman's time has expired.
I'd like to speak in support of Congressman Crenshaw's legislation to reauthorize Children's Hospital GME. The Republicans wish to reauthorize this. It's the parties on the other side of the aisle that wish not to. I know firsthand that a physician's training is a lengthy and expensive process, which is why renewing CHGME to ensure that there is sufficient supply of pediatricians to meet demand is so important. The timely reauthorization of this program through 2028 will continue a legacy of over 20 years of supporting our healthcare providers. However, I'm also supportive of a ban on funding for hospitals that furnish puberty blockers, hormone therapies, and surgeries for the purpose of altering biological genitalia to minors. So, Dr. McNamara, is an XY chromosome assigned at birth?
I'm sorry, I don't understand the nature of your question.
Simple question. Is an XY chromosome assigned at birth?
We often don't do routine chromosome testing on infants.
So an XY chromosome would not be assigned at birth, nor would an XX chromosome, although you say that sex is assigned at birth. There's a lack of scientific evidence regarding the effectiveness of these medical interventions, especially among minors, which is why countries in Europe, such as Denmark, Britain, Sweden, have described treatments as experimental and are urging doctors to proceed with caution, and why they've changed their guidance. The purpose of healthcare is to treat and heal, and it's not of interest at the expense of physical and mental well-being of patients. What evidence, Dr. Grossman, do we have that the thriving Dr. McNamara talks about is because of hormones or surgery and psychotherapy, family support, regression to the mean, placebo effect, or some other confounding variable? After all, there have been no randomized controlled trials. Have there been randomized controlled trials, Dr.
There
McNamara?
have not. Randomized controlled trials are what are the gold standards, that gold standard, that is what we're always looking for in medicine. We do not have those kind of studies. As you said, there are variables, confounding variables that can interfere. If a child is going through these gender-affirming cares, so-called, the child may also be getting psychotherapy. The family may be getting support. how do we know that the improvement on the other side is due to the hormones or the surgeries or the psychological support?
Yeah, thank you. And I think to say that the federal government is not already involved in healthcare is either naive or disingenuous. We saw that throughout the pandemic, that federal and state governments were both involved in the doctor-patient relationship. As a veteran, I defended the constitutional rights of Americans. As a doctor, I swore to do no harm. Because I care about the physical and mental health of your children as much as I do my own
Thanks.
children, I support restricting federal funding for experimental care that is permanent and
Gentlelady's
irreversible
time's
in minors.
expired.
Thank you. I yield my time.
The chair now recognizes
Congressman Cringchaw, a champion for our young children.
I thank the gentleman, and look, I just want to make a few more points, and I want to run everyone through this thought experiment. So my daughter's going to grow up with a father with one eye. And at some point, she might say, I want one eye. Right? I identify as somebody with one eyeball. Which, by the way, is far less important than your gender, just physiologically speaking. And so if I take her to the doctor and I say, can you just enucleate that eye for us because she identifies as a one eye, she wants to be just like her dad. What would the doctor say? They'd say, you're crazy and I'm going to have you arrested. That's what they should say. And this is for a physiological intervention that is far less important than your actual gender and your reproductive organs. Like, we have to stop this madness. This has gone too far. I asked before about what evidence is there that there's benefit for these so-called standards of care. I mean, anyone can say that they have a standard of care, but it has to be based on some kind of evidence and research. And when you've done systematic reviews, which is, again, is the gold standard for how you come to a conclusion within the scientific community, systematic reviews of 61 other systematic reviews, and you find little to no evidence that there's benefits for this, maybe you just press pause. Maybe you just press pause. Because if we're doing permanent physiological interventions to children that have permanently disfiguring them for some hope of a benefit that is not conclusive, then maybe we should press pause. Like, that's all we're saying. Press pause. And actually, actually is even less than that. All we're saying is let's not put taxpayer money toward it. Right? This is no different than how this Congress deals with the Hyde Amendment. This is a controversial issue. Abortion is a controversial issue. And so we say, look, we disagree on this, so let's make sure we don't put taxpayer funding toward it. That's all this bill is. Let's not put taxpayer funding towards something that is so obviously unproven and contentious. Actually, I don't even think it's really not that contentious. 70% of Americans oppose it. So it's actually, the American people are pretty much on the side of not doing this, or at least pressing the pause button. Dr. Grossman, you're a child psychiatrist. Can you expand upon the profound lack of clinical reviews and the long-term impacts of these treatments, puberty blockers, hormones, and surgeries?
Well, yes, as I said, we don't have the kind of studies that we would like. And I think it's very important for people to understand that when we talk about standards of care and we talk about guidelines and all the various associations that have come out for gender-affirming care and about politics and partisanshipness, those organizations themselves are rife with politics. They are permeated with politics.
Can you expand on that? Tell us how those activists have pressured dissenting voices in this
Well, yes,
field.
I just interviewed a number of doctors for my book, pediatricians, endocrinologists, who reported back to me on the fact that when they tried to speak up and have panel discussions or presentations that challenged gender-affirming care at the American Academy of Pediatrics or at the Endocrine Society, they're simply not given that opportunity. Even people, who have writing articles, the articles are turned down by a lot of journals. People have to understand that politics medicine, unfortunately, is permeated with politics at this point. Now, ideally, we wouldn't be stepping in. Who wants the government stepping in between doctors and parents and children? Of course, we ideally don't want that. But when there's something that is so wrong that's going on, then I think we have to.
Time.
Thank you, and I yield back to Mr. Pence.
Yeah, Mr. Pence yields back. The chair now recognizes, seeing that all members of the subcommittee have been recognized, the chair has now recognized Ms. Jakowski for 5 minutes for questions.
But I really now feel obligated, and it's a privilege to now talk about, as the only parent, I think, in this room, or grandparent of a trans young man, someone whose life has been enormously improved because of his ability, born as a girl, but finding his true self now as a young man who is living the life that belongs to him. He is now graduated from college. He is teaching school. He is living with his girlfriend, and fortunately in a place where he has the opportunities to get the care that he needs and has throughout the period that he needed it. And so, Dr. McNamara, I want to thank you, first of all, for your voice. And I wondered if you could just enumerate some of the other falsehoods that we are hearing and that I have experienced now in my family's lifetime.
Thank you. So first of all, regarding standards of care, that is not just a casual term. The standards of care that outline how gender-affirming care should proceed for people of all ages, including adolescents, have been published in reputable journals. The Journal of the Endocrine Society has published their extensively vetted guidelines, which they have issued several times after re-examining the evidence. The World Professional Association for Transgender Health issued the 8th edition of the Standards of Care, which is based on peer review of hundreds of global experts who basically performed systematic reviews in partnership with Johns Hopkins. The AAP has also issued statements that issue kind of practice guidelines that are taken very seriously in our community. Now, I want to address the low-quality evidence argument that comes up a lot, and it's critical that we all understand here today that that is a technical term, and that when it's used for public consumption, it can be quite confusing. There are ways to grade evidence using a very specific rubric where the number of study participants, the length of follow-up, et cetera, is assessed. In medicine, we recognize that all clinical care is different, all clinical research is different, and the practicalities of conducting studies are different. Low-quality evidence means that there is a basis of evidence, and it often informs strong recommendations for care.
Thank you for that. And I also want to see if you could actually help us understand the kind of work that is done with families. You would think that these children are snatched away and taken someplace and done, but isn't there a whole process that patients and their families go through? And if you could tell us about that.
Yes, ma'am. Well, oftentimes, the care begins with long conversations that take place over months and months, where families hear about all of their options. Parents hear about the risks and the benefits. They hear about various options. They ask lots of questions, and the young person gets mental health support.
And finally, let me just say, if you could speak to the importance of having both behavioral health care and also the medical needs of these kids, how both are so important. It's implied that it's only, the...
Gender dysphoria is real, and it needs to be diagnosed by a specialist. That is the standard of care in this country. Medical care does not proceed unless a mental health specialist has diagnosed this condition.
Thank you.
Thank you.
I yield back.
Gentlelady's time has expired.